All right, let's talk about Lasix. The first thing we talk about is why is it called Lasix, right? So, if you think about it, the way it was named is because it lasts for 6 hours, and that is why it is called Lasix, right? And now, how is that clinically relevant? Well, I found it to be relevant to my practice in a few ways. One is if I know that it lasts for 6 hours, I know when to check for urine sodium, if that's what I'm going to do, and more on that later. Why do I check urine sodium? But also, two is that I know if I give Lasix to my patients at 8 p.m., let's say, that they are going to pee up until 2 a.m., which I would not want on any of my patients. So I would know that I should not dose it at 8 p.m., right? I dose it very early on. Other thing to know about Lasix is what is the mechanism of action. And all of us know that it blocks sodium potassium 2 chloride channel, specifically the 2 chloride positions of sodium potassium 2 chloride channel in ascending limb of loop of Henle, right? We can call that channel, that the whole protein, the Lasix channel, and that way it'll be an easier conversation. By blocking the Lasix channel, specifically in the 2 chloride portion, it blocks sodium, potassium, and 2 chloride to be absorbed. So it excretes sodium, and by doing that, it excretes free water, because free water always follows sodium. Now, some of this sodium and with it free water is reobserved in sodium chloride channel in the distal convoluted tubule, DCT, where the thiazide work, right? And that is why sometimes when we have to augment Lasix, we give metolazone to block that channel so that the sodium that has been blocked by Lasix from ascending limb of loop of Henle does not get reabsorbed with free water at DCT. And that is how we can augment Lasix. These Lasix channels are present on the luminal side, and what I mean by that is, if this is the nephron, this part is where P is, right? This is the lumen, and this is the basolateral side. Basolateral side is where blood is, right? The cells are here, and the channels are here. So these Lasix channels are present on the luminal side of the nephron, and thus for Lasix to work, right, it has to be here. Lasix molecule has to come here. Only then it'll work. If they were to be protein bound and travel in blood, they will end up in basolateral side, and it is not okay. That way, Lasix will not reach its site of action. So how does Lasix reach here? Lasix molecule basically reach this Lasix channel mostly via secretion into the lumen. Mostly secretion, that is because they are protein bound, so filtration is difficult because of the charge barrier and the size barrier, right? And this is relevant clinically to me because unlike many other medications, for example, antibiotics or antiepileptics, we tend to increase the dose of Lasix, right, if required in CKD. And that is why, because then I need Lasix to be secreted by a diseased kidney to reach this Lasix channel. So I need a diseased kidney to work more, which it probably won't do for me, so I give more Lasix. Now let's talk about how do you dose Lasix for, let's say, heart failure exacerbation. There are basically two reasons, if not more, why absorption and hence bioavailability will be variable during heart failure. One of that reason is what is classically taught, gut edema. If you have edema everywhere else, you probably have edema in your gut as well. So one of the reason is gut edema, and that can hamper your absorption. And the second reason is decreased gastric transit time, so that will hamper the absorption as well, and hence the bioavailability. So in terms of like dose forms, right, IV is probably better than oral, at least initially. It is a good idea to usually give them higher dose than their home dose. The general advice is 2 times the oral dose they have been taking, right? What is the conversion factor for IV versus oral Lasix? And usually the potency of IV is twice that of oral Lasix, and that is only reflective of the bioavailability. So bioavailability of oral Lasix is around like 50%. So it only makes sense that if you give all of it IV, then it'll be twice as potent. So after you give Lasix twice the oral dose in IV form, you'd want to check for whether or not it is effective dose, right? How do you know if it is working? There are basically 4 ways to know that. One is you can do input-output monitoring. Sometimes it's very difficult to get that in the wards. The goal is to get around like 2 to 3 liters of urine output for dose. Because sometimes it's very difficult, you can also like ask the patient. So the other way is you can weigh them. Daily weight is essential to like know whether or not your Lasix is working. You need to know the dry weight of patients. Usually their last discharge summary is a good place to find the dry weight. The third way you can find whether or not your Lasix is working is by doing physical exam, right? So physical exam things like wrinkling of the edematous lower extremity, so decreased edema and then wrinkle that follows. It can also be decreased jugular venous distension. It can be decreased or absent S3 that was present before, so on and so forth, right? And the fourth thing that sort of like ties to what I was sort of touching on before is urine sodium. It blocks sodium potassium 2 chloride channel, so it only makes sense the urine sodium should increase, right? So if urine sodium is more than 100, that will give us a pretty good idea that Lasix is working. Let's say the dose is, let's say, not working, right? So what do you do? The first thing is you need to increase the dose. And this is something that we need to understand. Say you have like around 1 million nephrons in each kidneys, right? And you give Lasix. You would block some of the Lasix channels in certain number of these nephrons, right? Because when you dose Lasix, you're giving certain number of molecules of Lasix, and a fraction of it is reaching the kidneys on the luminal side, and a fraction of it is working by binding to the chloride channels. Certain number of nephrons are blocked, let's say. If that did not work, blocking them again in a few hours won't work either, correct? You need to block more channels, and hence you need more Lasix molecules at the site of action, which is the luminal site, right? Hence, increasing the dose is what you need to do, and increasing the frequency is what you would want to avoid. Once you find the dose that works, right? Once you know that, hey, not 40 mg IV, but let's say like 80 mg IV is what works for this patient. So those 4 things: urine sodium, weight, physical exam, finding input output. And to be fair, I think initially, like urine output, the patient telling you that they have been peeing a lot, and urine sodium might be easier things to look at, but also physical examination finding like JBD and S3 decrease pretty dramatically if the dose works. So once you get the right dose, you still want a faster diuresis, right? Only then increasing frequency makes sense, but you'd have to be reasonable about it. So that is how you think about Lasix in the wards. In next video, we will talk about what are the labs you need to monitor when you are giving Lasix to a patient and why. Till then, take care.